Hello, everyone, and welcome to Question Lab. We're happy to have you here. As always, tonight's topic is cardiology. And leading tonight's discussion one more time is Dr. Paras Vakaria. He's going to introduce himself now. Paras.
Thank you, Sean. Hey guys, my name is Paras. I'm a dermatology resident here in Dallas, Texas, and originally graduated from pharmacy school in Missouri and then went back home to Michigan to do medical school. I'm also an RX coach with USMLE-Rx, so I work one-on-one with students such as yourselves to help prepare you guys for the USMLE Step 1 and Step 2 CK as well, and I'm happy to help lead tonight's session.
I know I mentioned RX Coach earlier. RX Coach is our tutoring and coaching program, and we'll talk more about that later. But what I do want to mention for now is that we will employ a very similar methodology to the one that we employ during our coaching session. So without any further ado, let's get into our first question of the evening on the topic of cardiology. As you can see, the answer choices have been removed. That is by design. We do that so that you are not guided by the thought, your thought process isn't guided by the answer choices, so that you don't see an answer choice that you're unfamiliar with that may cause you to panic during the question answering process. So I've gone ahead and covered those up for you. Once we do that, we'd like to start with the lead-in. The lead-in is the last sentence or the question itself. And the reason we read that first is because we want you to know what the test writer is asking before you read the vignette, so you can pick up on all the relevant clues and save valuable time on testing. So let's read that vignette now. Which of the following left heart physiological changes is most likely in this patient? Which of the following left heart physiologic changes is most likely in this patient? After we do that, we'd like to ask our students how many steps they believe this question will require. An example of a one-step question could be where you ask for the diagnosis. An example of a two-step question could be where you ask for the treatment for a diagnosis. And an example of a three-step question could be where you ask for the mechanism of action for a treatment for a diagnosis. So I'll give you a few moments here to respond in the question box and let me know how many steps you believe this question will require. And then we'll read that vignette. All right, I see some responses coming in. Let's take a look at that vignette. A 40-year-old man comes to the clinic with increasing shortness of breath. He says it is worse with exercise when lying down to sleep. Blood pressure is 130/60. An early diastolic murmur is heard at the left sternal border with the patient leaning forward. Which of the following left heart physiologic changes is most likely in this patient? Paras.
Thank you, Sean. So what we're going to do is we're going to go ahead and show you what we think are the important clues in this vignette and the lead-in. And so starting off, we have a 40-year-old male. And that's generally the first information you're going to get in these clinical questions are demographics. And it's always important to make note of that because it can start to clue you in as to what diagnoses and things you should be thinking about. And then usually they tell you, why are they coming to the clinic? Why are they at the ER? And in this case, it's increasing shortness of breath. So you definitely want to make note of those presenting signs and symptoms, okay? A lot of times they'll also tell you how long it's been going on for, a few minutes, a few years, and that can give you a sense to the chronicity of the disease as well. So you want to make note of that, okay? Now in this question, they give us a little bit more about physical exam findings, some vital signs, and just a couple sentences there. So we can tell that there's going to be some important clues in those 2 to 3 sentences, okay? And then as Sean read, this is asking about a physiologic change, okay? So this question is asking about left heart physiologic change that's most likely to be seen. So I think we've got a couple steps here. I think one, we've got to figure out what is going on in this patient, what's the diagnosis, the condition, and then 2, what would we see changed physiologically in the left heart in that condition? So I think we've got a nice 2-step question here. So let's go ahead and let's take a look at those answer choices. And what we have here are 5 answer choices. And when we work with students, we recommend that they actually, as they're going through these, that they actually start at the bottom and work their way up to the top. So starting with answer choice E, and then working your way up to A. And the reason we do that is because a lot of times we'll see students who they'll start at the top, they'll see something they like, and they'll select it without having gone through all the answer choices. And so to help avoid making that mistake and avoid biasing yourself, we recommend doing it this way. So we'll go ahead and do that now. Answer choice E, increased stroke volume with decreased flow through the aortic valve. D, increased stroke volume and end diastolic volume. C, increased end systolic volume with decreased stroke volume. B, increased atrial pressure with low end diastolic volume. And A, decreased end diastolic volume with ventricular wall thickening. So those were a lot of words. We'll leave this screen up here for just a second, so you can make sure you're getting a good look at those answer choices, not getting confused. And then we'll go ahead and open up that poll. Go ahead and select the answer choice you think is the best answer, and we'll talk about it in just a few seconds.
Thank you, Parth. I'll go ahead and read some of these answer choices. E, increased stroke volume with decreased flow through the aortic valve. D, increased stroke volume and end diastolic volume. C, increased end systolic volume with decreased stroke volume. B, increased atrial pressure with low end diastolic volume. And A, decreased end diastolic volume with ventricular wall thickening. I see the responses coming in. We'll give all of you a few more seconds here. Remember that there is no penalty for guessing on test day. You should never leave a question blank. And if you're unsure about the answer choices tonight, don't worry, take your best guess, and we'll explain the correct and incorrect answer choices in just a moment. All right, I see about half of you have selected your answers. We'll give all of you a few more seconds here. All right, well, let's take a look and see what all of you selected. Looks like it was close. 26% of you selected C, which was increased end systolic volume with decreased stroke volume. In second place with 25% was answer choice D, and then we had A. So pretty close here. Let's see what the correct answer is. And the correct answer is D, increased stroke volume and end diastolic volume, and 25% of you got it right. So definitely a challenging question. If you got it wrong, don't worry. Pay attention to Paris now, and you'll be a master. Paris.
Thank you, Sean. Yes, definitely a tough question. So let's take a look at what's going on. Well, we've got a 40-year-old male with a diastolic murmur that is early, and it's heard at the left sternal border when the patient leans forward, okay? On top of that, we see that blood pressure is 130/60, and that difference between the two is what we call pulse pressure. That pulse pressure is a little bit wide, 130/60, a little bit what we call widened pulse pressure. So this patient probably has aortic regurgitation, okay? Now this can be due to rheumatic heart disease, or it can be due to a congenital bicuspid aortic valve, and maybe more common in a younger patient like this. So let's take a look at the next slide, and this is kind of going over aortic regurgitation. It is an early diastolic murmur that you can hear either at the base or the left sternal border, like in our patient, okay? You can also see a couple other things like wide pulse pressure, okay? There's some important associations and causes you need to know, whether it's a bicuspid aortic valve, endocarditis, dilation of the aortic root, or rheumatic fever, okay? This patient probably has chronic aortic regurgitation. Now, if we take a look at the next slide, this is looking a little bit into the pressure volume changes that happen in aortic regurgitation, okay? And you can see there that the end diastolic volume is increased. And that's because when you have a bad aortic valve, blood from the aorta can kind of flow back into the left ventricle through that bad aortic valve. That's called aortic regurgitation, okay? So we have more blood at the end of diastole. That's called increased end diastolic volume. So what happens is when you've got that increased blood in that ventricle, well, your ventricle is going to pump more blood out than it normally does. That's called increased stroke volume. So you have more blood at the end of diastole, so you've got a more filled left ventricle. So that left ventricle, it's just going to contract some of that more blood. That's an increase in stroke volume, okay? So if we take a look now back at our question and our answer choices, hopefully you can see now why this is the best answer, D, increased stroke volume and end diastolic volume. Answer choice E would be talking about mitral regurgitation, okay? So the blood is going from the left ventricle both forward into the aorta, but also backward into the left atrium. And we're talking about a different murmur here. Answer choice C, this would be talking about aortic stenosis. So not as much blood is being pumped out by the ventricle during systole because it's pumping against a stenotic valve of the aortic valve. Answer choice B, this would describe mitral stenosis. Okay. So you've got limited flow through that mitral valve, so you've got an increase in atrial pressure, and you've got less blood in the ventricle at the end of diastole. Then lastly, answer choice A, this is talking about left ventricular hypertrophy. So less so much a murmur, more so just wall thickening due to hypertension or something like that. So the best answer choice here is D, but it did require coming up with the right murmur first as well. So definitely a tough question here.
Yes, definitely a tough question, but great job, everyone, and great explanation as always, Forrest. Let's move on now to our second question of the evening. Once again, the answer choices are covered up. That is by design. And we will begin with the lead-in. Which of the following ion channels is most responsible for the observed arrhythmia? Which of the following ion channels is most responsible for the observed arrhythmia? I'll give you a few moments here to respond in the text box, or in the question box rather, and let us know how many steps you believe this question will require, and then we'll read that vignette. All right, I see some responses coming in. Let's get into that vignette. A 71-year-old woman comes to the physician for a routine examination. She says she feels well. She has a history of diabetes mellitus and hypertension, well controlled on metformin and enalapril. The ECG is shown. Which of the following ion channels is most responsible for the observed arrhythmia? Forrest.
Thank you, Sean. So once again, we're going to go ahead and show you what we think are the important clues in this vignette and the lead-in. Okay. So now we have a 71-year-old woman, and we know they tell us that she feels well. So this is something where, you know, she's not necessarily presenting with signs and symptoms. There may be some clues in that vignette, but we know we are given an EKG, and they actually tell us there's an observed arrhythmia. And that's important because when Sean read that lead-in, we can then look in that vignette and figure out, are there any clues there that could be related to an electrical abnormality. So in this question, they're asking us specifically about an ion channel most responsible for the observed arrhythmia. So I think we've got a couple questions here. I think we've got to figure out exactly what is that observed arrhythmia, and then two, what is the ion channel most responsible for that? So I think we've got another nice two-step question here. So let's go ahead and let's take a look at those answer choices. Actually, let's take a little bit of a zoom in on that EKG just so you guys can get a nice, good look at this EKG. It's going to be very important going forward and for the rest of your medical careers that you can correctly look at an EKG and detect both normal and abnormal rhythms. So definitely a very high yield topic, both for step one and the rest of your life. Don't worry, we'll move on to the next slide, but don't worry, it'll still be there in the corner. Answer choice, and once again, we will start at the bottom of the answer choices and work our way up to the top. Answer choice E, transient T-type calcium channels. D, potassium protein channels. C, fast voltage gated sodium channels. B, cyclic nucleotide gated funny cation channels. And A, L-type calcium channels. So we're going to go ahead and open up that poll. Go ahead and select what you think is the best answer here, and we'll talk about it in just a few seconds.
Well, thank you, Forrest. The poll is open. Once again, we'll wait until about 2/3 of you have responded. I see the responses coming in. Remember that we do have a raffle and a special offer at the end, so make sure you stick around. You might be a lucky winner. All right, I see about a third of you have responded. We'll give all of you a few more moments here. Next week's topic, by the way, is cardiology. Sorry, next week's topic is pharmacology. All right, let's take a look and see what all of you selected. In first place with 38% was potassium protein channels, and in second place we had cyclic nucleotide gated funny cation channels. So let's take a look and see what the correct answer is. And the correct answer is B, and 25% of you got it right once again. Cyclic nucleotide gated funny cation channels. Let me hand it off to Paris. We can explain it to us. Paris.
Thank you, Sean. Yes, definitely another tough question. So let's take a look at what's going on. You know, if you take a look at that EKG, you know, the one thing that stands out, especially when you look at that at the very bottom, and you can really look at any lead, but just how widely spaced the QRS complexes are. It's a little bit too slow. And if you count it out, whether, you know, there's various methods to count it out. You can use the big box method, you can use instruments as well. But the patient actually has a heart rate of about 45. And that's obviously bradycardia. Anything less than 60 beats per minute is sinus bradycardia. Okay. And so you can see now when you take a look that there actually are a lot of those big boxes between individual QRS complexes. And that would be consistent with bradycardia. Okay, and that's the observed arrhythmia that this patient has. So when we talk about bradycardia, we mean that the heart rate is slow. And we know that the heart rate is determined by the SA node. Okay, so when we talk about action potentials, they're different between pacemaker cells and myocyte cells. And so in this case, we're talking about the pacemaker cells of the SA node. They're firing too slowly. So let's take a look at the next slide. And remember, our action potential is different between, like I mentioned, between pacemaker cells and myocyte cells. We do not have all of those phases in a pacemaker potential that we do in a myocyte potential. Okay, we have phase 0, phase 3, and phase 4. And phase 4 is the important line here. The slope of that phase, phase 4, is really what determines your heart rate. Is that slope more elevated? Is that slope lower? And that determines a faster or slower heart rate. And you can see there at the very bottom that IF, that funny current, is predominantly the ion channel responsible for phase 4. If we move on to the next slide, there's a little bit more information about these pacemaker action potentials in first aid. And you can see there when talking about phase 4, you could see there that later on well, to begin with, it talks about how this is due to the funny current channels. So sodium, potassium movement, and these are the funny channels, okay? It then says how this accounts for the automaticity, and the slope of phase 4 in the SA node determines heart rate. So the slope of phase 4 is what determines your heart rate. There are different things that can slow your heart rate, as we know, and increase your heart rate, and they work primarily via this mechanism, changing the slope of phase 4, okay? So if we go back to our question and our answer choices, hopefully you can see now why this is the best answer choice. If you selected answer choice E, this was talking about transient T-type calcium channels. And you can see there in this diagram that, you know, transient T-type calcium channels do contribute a little bit, but they're primarily at the end of phase 4. They're not the main player for determining the slope of phase 4. Answer choice D was talking about potassium proteins and the efflux of potassium. And that's important for membrane repolarization, so phase 3, okay? Answer choice C was talking about fast voltage-gated sodium channels. And this is more important in myocyte cells, not action potential or pacemaker cells, okay? So answer choice C is actually not even relevant in this question. And then answer choice A, L-type calcium channels, this is actually also, as we talked about, not really involved in this process. So the best answer choice here is answer choice B, but it requires knowing the physiology and electrophysiology and the differences between pacemaker cells and myocyte cells. So definitely another tough question here.
Well, thank you, Paros. Yes, indeed, it was a tough question, but great job, everyone. Let's talk briefly about RX Coach. I know we mentioned it earlier. RX Coach is our tutoring and coaching program. So if you're studying for your board exams or a comprehensive assessment, what we will do is give you one of our assessments to take, and then based on the assessment, we will come up with a personalized study plan for you. If you're still in medical school, you're not quite there with step studying, we will then look at your syllabus and your learning objectives, and then we'll make a personalized study plan based on that. We'll take into account all of the resources you have, as well as all the ones that we provide to you. We'll do tutoring for step 2 as well. So we'll work with you one-on-one, help you identify your knowledge gaps, dissect questions with you on those topics to make sure you know how to answer questions. Your tutor will ask you questions like, what's important in this sentence? What are you thinking? What's on your list of differentials? Why is the right answer right? Why is the wrong answer wrong? And by doing all of those things, we really get to know you and really understand your learning style, what your strengths and weaknesses are. We can bridge those knowledge gaps and help you master those test taking skills. If you're interested in working with a coach one-on-one, reach out to us at rx-coach or rx-coach.com. You'll see a free consultation tab. That consultation is to discuss the tutoring program and how it can benefit you. So if you're interested, set up that free consultation. Let's have a chat and see if this program is a good fit for you. With that, let's go ahead and get into our third question of the evening. Once again, the answer choices are covered up. That is by design. And we'll begin with the lead-in. Which of the following best characterizes the hormone that was most likely measured? Which of the following best characterizes the hormone that was most likely measured? I'll give all of you a few seconds here to respond in the question box and let us know how many steps you believe this question will require. And then we'll read that vignette. All right, I see some responses coming in. Let's take a look at that vignette. A 72-year-old man presents to his physician with shortness of breath. He is unable to walk more than a block. And over the past month, his chronic leg swelling has worsened. The patient has coronary artery disease with 2 previous myocardial infarctions and chronic obstructive pulmonary disease requiring 2 liters of continuous home oxygen. The physician measures a hormone level to help distinguish a cardiac from a pulmonary cause of the patient's symptoms. Which of the following best characterizes the hormone that was most likely measured? Boris.
Thank you, Sean. So once again, we're going to go ahead and show you what we think are the important clues in this vignette and the lead-in. So now we've got a little bit of an elderly male, a 72-year-old man, and they tell us he's coming in because of shortness of breath, okay? Now they give us some other very important clues, medical history, what he's doing at home, and also, as we knew from Sean reading that lead-in question, it asked us about a hormone. So we definitely want to pick up on those clues that are relevant to that topic. And so in this case, they're saying measuring a hormone level to distinguish a cardiac from a pulmonary cause of those symptoms. So I think we've got a few steps here. I think one, we've got to figure out maybe what's going on with this patient. What's the condition diagnosis? 2, what is a test you can order, a hormone test you could maybe order to distinguish what they just mentioned? And then 3, I think they're then further going to ask us to characterize that hormone. So I think this might be a 3-step question. So let's take a look at those answer choices. And once again, we're going to start at the bottom, and we're going to work our way up to the top. Answer choice E, serum levels are elevated in both systolic and non-systolic heart failure. D, it is mainly secreted by the cardiac atria. C, it acts to decrease venous capacitance and increase preload. B, is primarily secreted in response to hypovolemia. And A, causes renal sodium retention. So once again, we're going to go ahead and open up that poll. Go ahead and select what you think is the best answer here, and we'll talk about it in just a few seconds. And just, go ahead, Sean.
No, go ahead. I'll go ahead and read these answer choices out one more time. Answer choice E, serum levels are elevated in both systolic and non-systolic heart failure. D, it is mainly secreted by the cardiac atria. C, it acts to decrease venous capacitance and increase preload. B, is primarily secreted in response to hypovolemia. And A, causes renal sodium retention. So we'll give all of you a few moments here to select your answer choices. You said about a quarter of you have responded. All right. And keep in mind, we do have that raffle and special offer coming up after our next question, so make sure you stick around. All right, with half of you have responded, we'll give all of you a few more moments here. Once again, next week's topic is pharmacology, so we hope to see you. Once again, next week, same place, same time. All right, well, let's take a look and see what you selected. %47 of you selected it is mainly secreted by the cardiac atria, and 22% of you selected serum levels are elevated in both systolic and non-systolic heart failure. So let's take a look and see what the correct answer is. And the correct answer is E, and 22% of you got it right. Serum levels are elevated in both systolic and non-systolic heart failure. And with that, I'll hand it off to Paris.
Thank you, Sean. Yes, definitely another tough question here. So let's take a look at what's going on in this question. Well, you know, this patient has shortness of breath, they've got unable to walk, and they've got leg swelling, okay? So hopefully you guys are picking up that this patient probably has heart failure, okay? And one of the tests that we can check in heart failure, as you guys may know, is BNP. BNP stands for B-type natriuretic peptide. B-type natriuretic peptide, okay? It's helpful in the diagnosis and also a little bit in the management of heart failure as well. Now, this is a hormone released primarily by the ventricles, okay? Not the atria, that's ANP, atrial natriuretic peptide. This is BNP. And this hormone is released in response to too much fluid or too much pressure, both of which we see in heart failure, okay? And BNP levels can rise both whether it's systolic heart failure or diastolic heart failure, okay? So you can't really use that to differentiate between the two. That's based more on your clinical presentation. But it is elevated and can be elevated in both types, and it is mainly secreted by the ventricle. So if we take a look at the next slide, this is a nice little tidbit from first aid about BNP. It is released from the ventricular myocytes. So it works similarly to ANP, but it's released from different cells, okay? So now, if we go back to our question, you can see why that's the best answer choice. Answer choice D is talking about ANP, or atrial natriuretic peptide, a little bit different. C, decreasing venous capacitance and increasing preload. This would be something that's more sympathetic, not what we would expect in this setting. Answer choice B, something secreted in response to hypovolemia. That would be more like vasopressin or aldosterone or renin, kind of the opposite of what's going on here. And then lastly, causes renal sodium retention. That, again, that would be something like aldosterone or renin, the opposite of what's going on here. So this was a question I think a lot of you guys maybe knew what the hormone was, but it was that third step of knowing what it secreted from that was a little bit tricky. So another good, tough question here for you guys.
Well, thank you very much, Boris. Another tough question indeed. Let's move on to our last question of the evening. And then, of course, we'll have our raffle and special offer. Next week is our 100th question lab. So make sure you join us. It'll be a very special question lab, and we will be covering pharmacology. Once again, the answer choices are removed, and we will begin with the lead-in. Which of the labeled cardiac structures is most likely enlarged in this patient? Which of the labeled cardiac structures is most likely enlarged in this patient? I'll give you a few seconds here to respond in the question box and let us know how many steps you believe this question will require. Then we'll move on to that vignette. All right, I see responses coming in. Let's take a look at that vignette. A 63-year-old man comes to the emergency department because of worsening shortness of breath for 2 weeks that awakened him from sleep tonight. He had a myocardial infarction 2 years ago, and he has had intermittent lower extremity edema in the past 6 months. He does not have chest pain. Pulse is 120 per minute, respirations are 22 per minute, and blood pressure is 111 over 70. Oxygen saturation is 88% on room air. Lung auscultation reveals bilateral pulmonary crackles and a systolic murmur that obscures the first heart sound. An echocardiogram from a healthy heart is shown. Which of the labeled cardiac structures is most likely enlarged in this patient? Paris.
Thank you, Sean. So once again, we're going to go ahead and show you what we think are the important clues in this vignette and the lead-in. And you can see that this is kind of a mix of things. We've got a clinical, but we've got a radiographic image as well. Okay. Now, we've done this a few times today, so hopefully you guys are starting to pick up, and what are those important clues in the vignette and the lead-in that we need to pick up on to get these questions right. Okay. Now in this question, again, we've got an elderly male, we've got a 63-year-old male, and he's coming in for worsening shortness of breath. Okay. Now in this question, they actually do give us a little bit of chronicity. They give us the time frame. This has been going on for 2 weeks. Okay. They give us some more medical history, some vital signs, all very important. Some physical exam findings as well. Okay. And then they tell us that there is an echocardiogram from a healthy heart that is shown. So this question is asking us, which cardiac structure labeled is most likely enlarged in this patient? So I think we've got a few steps here. I think one, we've got to figure out what's going on in this patient. What's the condition, the diagnosis? 2, what structure would be enlarged in that patient? And then 3, where does it correspond on the diagram or on the echocardiogram? I think we've got another nice 3-step question here. So once again, we're going to go ahead and open up those answer choices. We'll take a look. Actually, we'll take a little high-res look at that echocardiogram. And once again, remember, this is an echocardiogram from a healthy heart, is what they told us. Okay. So we'll go ahead and move on and go ahead and select what you think is the best answer here, and we'll talk about it in just a few seconds.
All right. Well, the poll is open. This is our last question of the evening. Let's try to finish strong. And of course, we'll have a raffle and special offer. I see responses coming in. About a third of you have responded. We'll give all of you a few more moments here. All right. Half of you have responded. Just a few more seconds here. All right. A few more seconds here. I see it's pretty close so far. Let's go ahead and take a look and see what all of you selected. In first place with 29% was answer choice B. In second place, we had D. And in third place, we had C. Let's take a look and see what the correct answer is. And the correct answer is C. And 21% of you got it right. So another challenging question on the topic of cardio here. Let me hand it off to Paris.
Thank you, Sean. Yes, definitely another tough question. So let's take a look at what's going on. Okay, so first step is figuring out what's going on in this patient. Okay, now we know this patient has a history of MI. Okay, and now also they are having issues with oxygenation. Okay, patient also has crackles in the lungs, which means there's probably fluid there, and a systolic murmur that is obscuring S1. Okay. So that would mean, if you remember what causes S1, that would mean that this patient might have an issue with the mitral valve or the tricuspid valve. Okay. And if we think about it, this patient had an MI. Okay. So there's potential for that to have caused valvular damage. We know that the first heart sound is resulting from the closing of the mitral and tricuspid valve. So if there's something that is obscuring that first heart sound, it might be that that valve that makes the first heart sound is involved, like the mitral or tricuspid valves, okay? Now, because we know this patient has pulmonary edema and crackles, it's probably more likely that it's the mitral valve that's bad, and that's causing blood and fluid to back up that then backs up into the lungs, okay? If it was the tricuspid valve, we would be dealing more so with peripheral signs and symptoms of fluid overload, okay? So this patient, if we had to guess, probably would have mitral regurgitation. And we know that based on, one, that it's a systolic murmur, okay? Two, it is obscuring the first heart sound. And three, we have pulmonary findings instead of peripheral findings. So that's how we know it's mitral, not tricuspid. So this patient probably has mitral regurgitation, okay? So what happens is we get more blood when the ventricle contracts. Yes, some blood does go out through the aorta, but also some blood goes back into the aorta, and that's not normal, okay? So what ends up happening is the left atrium gets more blood than it should be getting from that regurgitated valve, and that can lead to left atrial enlargement, okay? That can lead to a few things. That can lead to pulmonary issues. That can lead to atrial fibrillation as well, okay? So the structure that is most likely enlarged here is the left atrium, okay? And sometimes echoes can be a little tough to interpret because it's different than how we normally are used to seeing a heart. But if we take a look at the next slide, this is kind of a nice little tidbit from first aid that kind of points out, this is kind of how the heart is situated when you look at it in cross section, okay? The left ventricle, the left atrium really is the most posterior part of the heart, okay? So now if we take a look at the next slide, this is kind of a little bit of a normal diagram of an echo, and it shows how an echo is interpreting that heart anatomy. And one of the ways that I always like to look at it is when you see this image, we know that the left ventricle is thicker than the right ventricle, right? So when you look at that echo, you could see there that the wall surrounding the left ventricle is a little thicker than the wall surrounding the right ventricle, okay? And that's also another sign that you're looking at the left ventricle, a little bit of a thicker wall, okay? So from there, we can always work backward. And the apex of the heart is usually at the very tip, very top, okay? So let's go back. Let's take a look at our question. Hopefully now you can see how B here is the left ventricle. C here is the left atrium, which is most likely enlarged in the setting of chronic mitral regurgitation. Answer choice D is the right atrium, A is the right ventricle, and E is the apex of the left ventricle or the heart. So all incorrect answers in this question. So definitely some challenging cardiology questions, but these are definitely fair questions and ways that they love to add those extra second and third steps and also incorporate some imaging and electrocardiography as well. So great job on tonight's questions. I will hand it back to you, Sean.
Well, thank you very much, Boris. And thank you everybody for attending. If you want, we always provide our question ID so that you can make note of them, take a picture, take a screenshot, write them down. You can type these into the RX search field, and if you want to take a deeper dive into these topics, you can do that by simply typing these numbers into the RX search field in USMLE-Rx. So I'll give you a few seconds here to make note of these numbers. All right. As always, we encourage you to stay connected with us. We're on YouTube, where we post all of our webinars and question lab videos and other great things. On Instagram, we're on Twitter. We have a blog, firstaidteam.com, which has a lot of great free resources, announcements about upcoming events, as well as our free study planner that you can download.